following is a production of West Virginia Public Broadcasting.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
Welcome to Doctors on Call. Tonight's topic, headaches. Two experts are here to answer your questions. Now here's your host, Dr. Raleigh Sullivan.
Good evening. More than 45 million Americans suffer from some form of chronic headaches, and more than half of them are dealing with the intensive pain of migraines. But whether it's a chronic condition or occasional pain, you don't have to live with it. What kind of headache do you have? When is a headache a sign of something more serious? And what are your treatment options? We're going to get those answers to those questions and more tonight from our two guests, Dr. David Watson, a neurologist at WVU and director of the WVU Headache Center, and Dr. Tracy Weimer, also a neurologist at WVU, whose special interests include neurophysiology. If you'd like to ask our guests a question, give us a call. Our phone lines are open now. And so, David, let's start with you. How do you determine what kind of headache a patient has?
Well, it's sometimes not very easy, but primarily headache diagnosis is done through taking a history. A huge majority of the information we need comes from the story that the patient tells about when their headache occurs, what it feels like when they get it, what causes it to occur, what treatments they use to get rid of it. Sometimes we have to do testing like MRI scans or CT scans, but for the most part, we take a history, we do an exam, and we can usually come up with a pretty good handle of what the diagnosis is. Okay, and I assume there's lots of different causes for headaches that we're going to get back to talking about here after a bit. But primarily it's by history, you're saying? Primarily. Okay, well, Tracy, let's get you into this. Sometimes a headache can be a sign of something more serious.
Exactly. There are primary headaches and secondary headaches. Primary headache means it's the headache by itself, and those include things like migraines and tension headaches. And then there are secondary headaches, which means there's something underlying it, some kind of pathology that causes the headache, and that would be something like infections or tumors or blood vessel abnormalities. Mm-hmm. And that's part of the history taking. You have to try to figure out which kind of headache is this, primary or secondary.
Whenever we talk about headaches, it's interesting because oftentimes patients will come to me, and if they have a bad headache, they always say they have a migraine, quote unquote, I have a migraine. And yet, those of us that do this sometimes think about tension headaches as being very common. And I thought maybe we could talk a little bit about what a migraine headache is and what a tension headache is, which I think are two of the most common, if I'm not incorrect.
Sure. Well, by far, tension headache is the most common headache that people experience. By far.
Tension, okay.
But most of those headaches are mild to moderate headaches, and very few people actually seek health care for their tension headaches because it's the headache that we've all had. And you either ignore it or you take something over the counter, and for the most part, it goes away. When people with tension headache start getting into trouble and start seeking health care, it's usually when they develop chronic tension headache, meaning that the headache starts to become every day or almost every day. But for regular tension headaches, most people just deal with them and get through them. Migraine is by far the most common headache that causes people to go see a doctor. And there have actually been some studies that looked at, in primary care doctors' offices, if someone's in a waiting room and they want to talk about headaches, what kind of headaches do they have? And about 90% of them actually have migraine headaches. So when patients come and say that they have a migraine, more often than not, they're right, but we do have to then back up a little bit, take that history, and make sure that what they're talking about is migraine, because just because your mom had migraine doesn't mean that your headaches are migraine. We have to make sure that we're not missing something else.
Okay, well, let's talk about what a migraine, if that's what takes people to doctors, let's talk about what a migraine is.
Migraine is usually one-sided. It's derived from the Greek word for hemicranios, which means half of your head.
Half of your head, huh?
So it's usually on one side or the other. It's usually associated with other symptoms like nausea, vomiting. People who have migraines are usually people who want to go into a dark room and lie still, be quiet. It gets worse when you do things like go upstairs. Any kind of exertion will make it worse. It's usually more common in women than men.
Any particular age when this is likely to show up?
Well, it can be in children.
You see it at all age groups, but you really see it start to take off in women around the age of puberty. And then in both age groups probably hits its peak in the mid-20s to mid-30s.
You said it starts in puberty. Does that imply that there's maybe a hormonal component to this?
Well, estrogen is a very common trigger for migraine, which is probably why until the age of puberty, you see that the frequency of migraine is about the same for boys and girls. And then at about age 12 or 13, you see a rapid rise in the incidence of migraine in women that you don't see occur in men. And then it ends up being that women have about 3 times as many migraines as men do. And some of that has to do with estrogen fluctuation being a natural triggering event for migraine headaches that men don't have to deal with.
What's the, I guess I'm curious about this, but what's sort of the natural history of a migraine attack if you don't do anything about it?
It varies. Some people will have migraines that last a couple hours. Some people will have them that last a day.
A couple hours only?
Yeah, some people will have them that last a day. I've had people that have had migraines for weeks.
For weeks?
Mm-hmm.
Can patients tell when they're going to get migraines?
Sometimes, and that's actually an area that's being looked at more and more right now, which is what's called the prodrome of migraine, which just means do you get weird symptoms beforehand that give you a warning that the headache is coming? And prodrome being different than the aura that a lot of people know about with the flashing lights in their eyes. Prodrome is even up to 24 hours before a headache starts, people will talk about having food cravings, feeling really tired, feeling really elated or really depressed. But it's some sort of fairly consistent symptom that they'll experience that's different from person to person that lets them know that a headache is coming. And it's become an area of interest in the headache community because it may actually lead to an improved ability to treat the headaches, because if we can find treatments that'll stop a headache before the pain even starts, then we'll be doing a whole lot better.
Well, that's interesting. So prodrome might be a craving for some kind of food?
Yeah, and kind of the one I like to think about is chocolate. Everyone thinks that chocolate is a trigger for migraine, and for some people, chocolate is a trigger for migraine.
Really?
But when they've actually looked at it, for some people, they develop a craving for chocolate as their prodrome. They go eat chocolate, they get the headache they were going to get anyway, and then they presume that chocolate was what caused their headaches. But oftentimes, I mean, the craving can be for any type of food, and that's just one of the different type of prodrome symptoms.
I'm fascinated by that. I hope we get a chance to get back to it. We have our first caller. This is Pansy from Tazewell County, Virginia, a long way off. Welcome to the show. You have a question for us?
Yes, I do. I do have a slip disc in my neck, and I have an ear problem. And as a child, before this ever happened, I had migraines so bad that I would cry in school and I couldn't learn. And so now I have pain on the right side going down to the back of my skull and up to the side here and out the side temple. And it's I keep it for about 4 days unless I keep taking pain medication to keep it away, keep it away, keep it away. That's all I know to do.
What kind of pain medication do you take?
Well, I'm 65, and I have a fatty liver, so I can't take Tylenol. So I'm on 10 milligrams twice a day of morphine because I have other problems, and Tramadol.
And Tramadol. Okay. One of you two want to take a shot at that?
Sure. I mean, I think she raises a couple of good points in this.
Yeah.
And it's a fairly common story, which is she had a history of having migraine headaches when she was younger. It means she probably is genetically predisposed towards headaches and may even be genetically predisposed towards other types of pain. She then develops some, what sounds to be some degenerative changes in her neck, maybe some arthritis, maybe some disc herniation. And then that acts as just a constant irritant to an already somewhat hyperactive system. So people that don't get migraine who get neck disease oftentimes get neck pain, but not terribly commonly would it progress actually up into head pain unless there's some reason or some predisposition towards getting headaches. So she probably is having a variant of her original migraine headache that's being triggered by the problems in her neck. Dizziness is also a very common complaint in people that have migraine, which is somewhat difficult to explain, but really points to the idea that migraine, although we think of just the pain as being migraine, is a much broader syndrome of neurologic dysfunction.
Yeah.
I think the other point she brings up that's interesting is the use of chronic pain medication for
I was going to ask you about that,
for pain, and it's a really difficult question because in headaches especially, there is fairly good evidence that shows that frequent use of short-acting pain medicine or even long-acting pain medicine that's the opiates can actually worsen the problem. That it actually has some changes in the way receptors are expressed in the brain, and maybe even iron deposition in some of the pain centers in the brain, and really can lead to a more chronic, more difficult to treat problem. It becomes difficult when people have other types of pain that might actually be well treated with opiates, and how do you find that balance? And it's a really difficult case.
Okay. Well, I'd like to get maybe back to that. We have another caller, though. This is Vicki from Allegheny County, Maryland. Vicki, welcome to Doctors on Call. You have a question for us?
Yes. I get severe headaches. The only thing that is weird is like my daughter has gotten migraines and that, but I only get them when I wake up in the morning. When I have a severe headache, a migraine, I don't get them during the day. It's when I wake up, I have them. I mean, to the point that I can't stay in light or, you know, I can't. It's just weird, and they can't give me no answers on why. And I don't know if there's a type of migraine that would cause that. But that's the only time I get them. When I wake up in the morning, I have them so bad I can't see straight. I'm nauseated. The minute I wake up,
Questions for her? Like, do you get these every day?
No, I get them about approximately 4 or 5 times a month, though. And it's always, I wake up. As soon as I open my eyes, I've got them.
Okay.
I never get them during the day.
I think one of the things you would think about was, you know, does she have sleep apnea? Does she snore? Does she feel sleepy during the day? What happens when you have sleep apnea is you don't breathe well when you're sleeping, and you can retain carbon dioxide, and that gives you a lot of headaches, and people wake up with headaches.
Yeah, and when folks tell me about morning headaches, if you read the textbooks, all the textbooks say you've got to get a brain scan. There's kind of the old literature suggests that morning headaches are a sign of brain tumors. I've never seen that be true, but that's what's in the textbooks.
It's funny because that's what I was taught.
Yeah.
I remember that, you know, and I don't think I ever saw it. If you haven't, I feel better.
But that's what's in the textbooks, is that morning headaches could be a sign of something serious. But much more commonly, like Tracy said, is an underlying sleep disorder that can cause that. The other thing is that if people drink a fair amount of caffeine through the day, then the longest time they go without caffeine is when they're in bed asleep. So they wake up in the morning with a caffeine withdrawal headache that then goes away when they start drinking caffeine again.
Gosh, we need to come back to that because that's such a huge issue for people.
We have a lot of things to come back to.
We really do. I hope we get through because we have another caller. We have Patricia from Taylor County. And Patricia, welcome to the show. You have a question for us?
Yes, I do. I'd like to know if you know what causes cluster headaches.
Great question. Who wants to take that one?
Cluster headaches, I'm not quite sure how to address the cause. They're exacerbated by alcohol or smoking.
You want to describe what they are first?
Yeah, cluster headaches are defined, they're usually, again, one-sided, and they occur in clusters, where that's where the name comes from. They'll happen, you know, they'll last for about an hour or two during the day, and you'll have several of them during the day. This happens over a period of, you know, weeks sometimes, and then they'll go into remission for months, and then they come back in another cluster. And like I said, they're usually more common in people who drink alcohol, people who smoke. They're usually more common in men. And they're another one that is triggered by sleep. What happens is when you go to sleep, you go into a stage called REM, and that seems to be a trigger for a cluster headache, and it wakes them up, and then they don't get enough sleep, and it sort of sets up a bad cycle where you don't get enough sleep, and the headache gets worse.
So what do you usually tell people with cluster headaches then? Even if you can't find the cause, do you say stop smoking, watch how much alcohol? I mean,
well, we have treatment. We have prophylactic treatment, which is usually a calcium channel blocker, verapamil. And then there's abortive care. Usually you can give these people a course of steroids and they do well with that, or Imitrex.
okay. Let me, but since I have a moment, I want to get back to the caffeine headache. Can we talk about that? Because it does seem to be a common problem. You want to sort of describe what happens, maybe why, if we know?
Well, caffeine is kind of a two-edged sword, which is that if you drink too much caffeine, it can cause headaches. If you drink caffeine regularly and then don't drink caffeine, it can cause headaches. And so it's very easy to get into a cycle where you just drink a lot of caffeine so that you don't get the headaches. But the problem is that with, like a lot of even over-the-counter medicines or prescription medications, with frequent redosing of the same chemical, in this case caffeine, you actually start to create more headaches over time. And actually one of the common over-the-counter medicines for migraine is Excedrin.
Right.
And Excedrin has a lot of caffeine in it.
Yeah.
And you know, if you have a headache once a month, it's probably a pretty good treatment. But if you start getting a headache a couple times a week, you start running into problems where the drug itself can start to drive the headaches more and more.
Can people, I'm curious about several things too, can people get more than one kind of headache?
Sure.
Okay, talk about that. I mean, sure, that's, okay.
Well, I mean, tension headache occurs in probably 70 or 80% of the population.
70 or 80% of people get it, okay.
Yeah. Again, it's the one that most of us have had at some point in our life. We studied too hard, we stayed up too late, whatever. And then migraine occurs in about 12% of the population, and about 18% of women get migraine. So there's pretty common to have some overlap with people that have episodes of really severe headaches who then have smaller headaches fairly frequently mixed in with it. There are some people that have migraine and cluster headache. And one thing we always have to remind ourselves is that
migraine and cluster.
And one thing we have to be careful of is that some people that have migraine headaches can also get serious headaches where something else is wrong with them. And so I'm always asking my patients if their headaches have changed, or to, again, describe their headaches to me, because just because they have the diagnosis of migraine doesn't mean that something else isn't going to happen where we have to rethink this idea of primary or secondary headache like we were talking about earlier.
Well, when you all get, somebody comes in, they come in for a headache workup, you want to just sort of talk about what it is that you might run through?
Well, usually you want to know how long have you had the headaches, how often do you get them, what are they like, what do you want to do when you get a headache, what have you taken for the headaches. You want to know, any kind of red flag you're looking for. Have you had a history of trauma lately? Have you had fever? Have you had weight loss? You want to try to find anything that might make you want a scan, or make you think of something pathological. You would ask about, neck pain. The lady that was talking earlier about her slip disc, that's an important cause of headache too.
Are there routine x-rays or scans that you get, or blood tests that you get? I mean, what sort of, I understand history is really important, of course.
Not routinely. If someone comes in and they tell a story that's fairly typical for migraine headache or one of the other primary headaches, and they have a normal physical exam, as long as they're in an age range that makes sense for them to have that kind of headache, meaning that they're in their late teens up into their mid-40s to start having this headache, oftentimes we don't order anything. Now, most of the patients that we end up seeing have already had some scans done by the time they get to us. But the reality is if someone comes and they don't have an MRI scan already, if they're in that group, they probably don't need one. You start worrying about it when they are either too young to be having headaches, so kids that are really in the single digits age, although most of them are still fine, that's an area where you would want to consider having a workup done. And then people who get into their 50s and older and start having a new headache, those people we probably need to worry about inflammatory things or other causes of headaches besides just a primary headache disorder.
Let's talk about it. I have two different things I want to talk about, but I want to ask you about sinus headache too, because that's a very common term that we all hear as doctors. Who wants to talk about a sinus headache for a minute?
Sinus headaches are greatly overdiagnosed, I think. Most of the time when people talk about sinus headaches, what they mean is headache associated with chronic sinusitis. And that's not, whether or not that even exists is sort of controversial. For the most part, when you get a sinus headache, it would be because you have an acute sinus infection and you have, fever and, a lot of discharge from your sinuses. It's not usually associated with the chronic sinusitis.
So when people say sinus headache, what do they usually, I don't know, what do they usually mean, you think?
I think most of them have migraine.
You think most of them have migraine?
That's located over the sinus area.
It's located over the sinus, and so that's why.
Yeah, and so one of the things that when migraine is being generated in the back part of the brain where there's a lot of different nerves going through there, the generator area for migraine, the trigeminal nucleus, which is the sensory part for the head, actually sits right next to another part of the brain that actually affects the sinuses and can cause sinus congestion and inflammation. So it's very common for people that have migraine headache to talk about having a feeling of fullness in their face or congestion or difficulty breathing. The other thing about sinus headache is that it's easy to be convinced that you have sinus headache because it's been well marketed.
It's been well marketed.
The lady on TV who holds her face like this and says, I have a sinus headache, and then I take whatever medicine it is and it goes away, she's probably actually describing migraine headaches. The difference is if you come to see me and you say I have a sinus headache and I put you on an antibiotic, you assume that within a couple of days you'll feel better, and you probably will, because migraine is usually a 4 to 72 hour headache, so the headache would have gone away on its own. But if I tell you that you have migraine and give you a medicine that's going to work in 2 days, you're not going to be very happy about it because you want a medicine that works to stop it right then.
Let's get this next caller in. It's Joyce from Ohio County, and I know we don't have much time. Joyce, welcome to the show. You have a question for us?
I'm getting migraine headaches for 40 years now, and I'm 73 years old. And the doctor has me on, it's called Floricet, and I've been getting migraines more often now when I notice a change of weather and I watch the certain foods that I eat. I don't know what else to do because I have no warning sign when this happens. My migraines will be anywhere from 1 day to 3, possibly 4 days. And I am in complete darkness in room. I have an ice pack on. I just don't know what else to do, and I get nauseated, I throw up, and then after the headache is gone, then I sleep for like about 24 hours, and I feel so exhausted.
How often do you take Floricet?
On here, it states three times daily, but there's times I've had to be taking it a little bit more than that, like about 4, maybe 5, and that would be in the 24 to 48 hour span.
About a minute, maybe you can.
So I'll try to go quickly. So in people that are older, certainly there's more concern about some of the treatments that are available because some of the treatments constrict blood vessels, and so if you start to develop a little bit of heart disease or a little bit of cerebrovascular disease, then using some of the drugs like Imitrex and its cousins can be a little bit more concerning. I'm always concerned about drugs like Floricet because they, like we talked about with caffeine and even with the opiates, can do the same thing, which is cause more chronic headaches.
Rebound chronic headache,
So, this is a much more difficult population to try to treat because a lot of the drug options aren't very good options, and this is actually somewhere where I would think about doing something like Botox injections in someone of that age.
Interesting. You've got about 30 seconds, Tracy. Anything you want to say about headaches that we haven't covered? He drug in Botox here at the end.
I think it's just important for people to realize that there are a lot of different ways that we can treat headaches. And I don't want people to get discouraged if one thing doesn't work because we have a whole lot of different things we can try.
Different options that we can use out there. Final word?
Just to echo that, everyone tells me they've taken everything and we can always find something else to try.
Right, you always find other things to try. It's too bad we didn't get to talk about some of the Imitrex and all the cousins. Now, we did talk a little bit about the opioids, but And I think we talked about that probably adequately at this point. It's sometimes a big problem. People are on chronic opioids. Okay, well, we've been talking about headaches with Dr. David Watson and Dr. Tracy Weimer. I want to thank both of you for being with us. If you'd like more information, talk to your family doctor or visit our website at wvuhealthcare.com. For Doctors on Call, I'm Dr. Raleigh Sullivan. Good night and good health.
Join us again next week for another edition of Doctors on Call.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
This has been a production of West Virginia Public Broadcasting.